So, sir, before we start, so like if the capital levels are high, they're blowing out CO2, right? They're blowing out more than they usually. Does that mean they're taking the CO2 out of their body and there's too low CO2 in their body now, or?
No, it's high. The body's producing a large amount. That's why they're blowing a large amount off.
Okay, so
They're trying to regulate that and bring all that CO2 down.
They're retaining it.
That makes sense. Yeah, because I didn't know if they were bringing it too much, if they were bringing out too much of it, if their body was.
If they do, that number will fall.
Yes.
It will be below 35 if they're getting rid of too much.
Okay.
All right. Page 5, hypoglycemia.
Gosh!
Here we go.
Fuck up.
Hypoglycemia versus hyperglycemia. All right. Hypoglycemia is sudden onset, usually after taking their what?
Insulin.
And not what?
Eating.
So here's what happens. Your alpha cells of the pancreas release glucagon. The beta cells of your pancreas release insulin. If I have more insulin than I have sugar, you are going to end up with no sugar in the cells. If I end up with no sugar in the cells because I had more insulin than there was sugar available, the sugar level in the brain is going to go down. The D-stick for an adult should be at least 80. 80 for D-stick on adults, 60 on kids, 40 on infants. Now, just because somebody is below 80 doesn't mean they're diabetic. However, if it's below 80 and they're altered, then we want to look at giving them sugar. All right? If you haven't ate today and we checked your sugar and it's 62 right now, and you're not a diabetic and you're just hangry and you want some food, that doesn't mean you're diabetic. Okay? Now, if you were on the ground, unresponsive, I don't know you, and your sugar's 60, and you can't tell me what's wrong, I'm going to treat your sugar to rule it out and see if that fixes you. Does that kind of make sense? So 80 for adults, 60 for kids, 40 for infants, with signs and symptoms. Now, if there's no sugar going to the brain, and the brain sugar level is historically 20 to 40 points lower than the finger stick. So if I have a blood sugar of 60 on my finger, I have a blood sugar of 20 to 40 in the brain. Because it's burning it so quick, it's not able to store it. So if I don't have enough sugar to the brain, how do I get sugar to the brain? I steal it from the extremities. So I'm going to steal all the blood and all the sugar from the extremities and push it back to the core. What drug helps squeeze all the blood from the extremities back to the core?
Epi.
So what happens is this person interprets low blood sugar as if they must be in shock, and if they must be in shock, they release the epi. The alpha effects of epi steal the red, warm oxygen and sugar from the extremities back to the core. So as a result of that, if I have no red, warm blood to the extremities, they become cool, pale, and clammy. Cool and clammy, give them some candy. Warm and dry, sugar's high, flush it by. So if I have a diabetic who's cool, who's pale, who's clammy, they don't have enough sugar, they release insulin to squeeze the sugar back to the core. That's why they become cool, pale, clammy. The lower the sugar, the colder to touch they will become, and the more diaphoretic they will become. Because the more epi they're using to shunt the blood from the extremities back to the core. That's why another name for hypoglycemia is called insulin shock. They have more insulin than they have sugar. It puts them into shock and they release epi. What do the vessels in the brain have to do to allow the increased blood flow from the extremities being squeezed into the brain? Both pupils will dilate. Because think about it, if I'm squeezing blood into the brain, the vessels in the brain have to make room for the increased blood volume and sugar volume. they'll get pupil dilation. So, Koppel clammy, altered mental status. They may also have slurred speech, dilated pupils. They may end up being tachycardic. Why would they be tachycardic? Because they're trying to pump that blood through constricted vessels up to the brain. And if they don't get enough sugar to the brain and epi doesn't work, they will do a hard system reset, which is a seizure. Think of it like this. Your computer is jacking up and it's not working and it freezes and you've tried everything. Eventually you just cut the power and then start it back over and hope it works. Seizures, a lot of times when we seize because of temperature, either hot or cold, we seize because of hypoxia or we seize because of sugar. It's kind of like, okay, everything's gone wrong. We've tried to compensate, start all over. And that's what a seizure is. It's like a system reset. So they didn't get enough sugar to the brain. They released a lot of epi. It didn't get any better. Now they'll seize to try and start the nervous system all over again. And that's why a seizure patient will end up seizing. If you respond to a diabetic and they're actively seizing and their blood sugar's 30, what do we do if they're actively seizing and their blood sugar's 30?
Stop the seizure.
Stop the seizure. Valium, Versed, or Ativan. Those are all benzos. All right? Registry usually wants Valium for seizures, Versed for sedation, Haldol for schizophrenia, and occasionally they'll throw in an Ativan, or they'll just say, what class of drugs do you give for seizures? Benzos. All right? Those are all benzos. Once we stop the seizure through the administration of Versed, in order to prevent the seizure from coming back, now we give them what? Sugar. The reason why we stop the seizure, stop and think about it. Somebody calls 911 for seizure activity. It takes you 1 to 2 minutes to get out to the ambulance. You have a 4 to 6 minute response time. By the time you put it in park, you grab your gear, you have a couple of minutes to get inside the house or the apartment. So about 8 to 10 minutes have gone by. They called for a seizure. 8 to 10 minutes later, the guy is still seizing. That's 8 to 10 minutes without oxygen. We got to stop that thing right now. Even if he had stopped seizing and then started again, he's never completely regained consciousness, so he's never reoxygenated himself. So that's just as bad as one continuous seizure. So we need to stop the seizure to where they can start oxygenating again, and then we'll prevent it from coming back by giving the sugar. All right? How do we give sugar to our diabetics?
D10.
Okay, if I can get an IV, D10. What if I can't get an IV? Glucagon. What if they're alert, conscious, and can swallow?
Oral candy.
Or glucose.
Oral glucose.
If you can't get an IV, and you don't want to drill them, and you can't give glucagon, but they can't swallow, what is a cheating method, so to speak, of trying to get a little bit of sugar to wake them up enough they can swallow some orange juice or something?
Or glucose on tongue depressors.
Or glucose on a tongue depressor and put it between the cheek and the gum. What route is that called? Buccal. Those of y'all that chew tobacco, you get nicotine through buccal administration. Now, what type of patients will glucagon not work in?
Alcoholics.
Alcoholics who don't have stored sugar reserve, hepatitis or liver cirrhosis maybe, or patients that have been hypoglycemic in the previous 24 to 48 hours. All right? If they've already bottomed their sugar out and now they're bottomed out again, they've never resupplied the stored glycogen in the liver. In order for them to have glycogen, they have to have eaten and replaced their sugar.
So in a patient that has a seizure and uses all the sugar stored, does that mean glucagon will not work?
It may not. Or it may take twice as long as normal. The other side of that is let's say we run out on diabetic X today. Yesterday they ran on diabetic X. They couldn't get an IV on him, so they ended up giving him glucagon. Obviously, if he's bottomed back out today, he is probably not taking his medicine and eating correctly. So do you think he's restored his glycogen stores yet? So it's probably not going to work. Or maybe family did it yesterday and gave him glucagon because more and more family members are trading home glucagon kits. So maybe it wasn't even us that ran out. But it usually takes 24 to 48 hours proper eating and proper medication to resupply restorative life.
That's, I gotta imagine, that's basically the only scenario where you do administration.
Correct.
Right?
Yeah. Yeah. And what every so often, and you just got to stop and think about it. It's if they were to say you have a patient, diabetic, altered level of consciousness, no IV access, glucagon is ineffective, and patient is unable to swallow, what additional routes could you consider giving sugar? And that's when they're looking at the buccal. Everything else is failed. All right? Everything else is failed. All right, so are we good on hypoglycemia? 80 adults, 60 kids, 40 infants, yes.
What's the doses on,
Stick a jelly right here.
well, percentage doses on sugar, like E50, E10? Because I know 25 to 50 on E50, but then where?
50%, 25%, and 10%. That's why it's called Z2.
Okay.
The 80-60-40 is adult, pediatric, and infant.
Yeah,
The
so
percentage for E50 you're looking for is 50%.
correct. It's called dextrose 50%. Here's how they got that number. D50 is 25 grams of sugar in 50 mils of fluid. It's 50%. D25 was 25 grams of sugar in 100 mils. D10 is 25 grams of sugar in 250 mils. It's just how much it's been diluted. That's all it is. 50% sugar, 25% sugar, 10% sugar. That's all it is.
So the PD dose is different though, right?
So they should not ask you any D50 or D25 questions. In the old days, in this, you probably had an old review test, and here's what it was. It was called the 50-cent rule. So D10 was for kids less than age 1. D25 was 1 to 12. D50 was greater than age 12 in years. So we had what was called the 50-cent rule. If I take 50 divided by 50, that equals 1. So the dose was 1 milliliter per kilogram. 50 divided by 25 is 2, so that was 2 mils per kilo. 50 divided by 10 is 5 mils per kilo. So that's how we would figure up how much sugar to give somebody based on weight. Adults got 1 mil per kilo of D50. Kids got 2 mils per kilo of D25. Infants got 5 mils per kilo of D10. But everybody now gets D10, so everybody gets 5 mils per kilo. However,
It was mils per kg something.
yeah, it's 5 mils per kilo.
Okay.
However, let's just be honest, an adult, we're going to give them a bag and see how they do. But for pediatrics, we need to be exact with our 5 mils per kilo. All right?
But that 5 mils per kg is on adult, that's on everyone. Okay.
Yes. 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 What are they doing out there?
They're putting in, lines.
Okay.
With a bulldozer?
Basically.
Well, nobody's supposed to be on campus because the college is closed. That's why they're doing it. All right, so any questions on the hypoglycemia?
Volume for seizures, according to the registry.
Do what?
You said volume for seizures, according to the registry?
Volume for
Valium.
Valium. Valium for seizures, Versed for sedation, Halidol for paranoid schizophrenia, or they just made what class. Those are all benzodiazepines.
Is there a reason there's a preference for each one?
Not really.
Okay.
Valium, with it being oil-based, they thought did a little bit better on seizures and the way it works on the nervous system. The benefit to Versed is it's water-based, so it can go intranasal, can also go IV-IM, and it works better as far as relaxing you and making you not remember stuff, versus Valium worked better on the actual neurological side of a seizure. And really, it's up to the medical control. I mean, you can use them interchangeably. We carried Valium forever up until, I don't know, I lose track of time, maybe 5 years ago. We switched over from Valium to Versed. They're pretty much interchangeable. And that's why they're moving more towards gibabenzo. Because that lets your medical director what? Pick. Do you want Versed, Valium, or Ativan? The other name for Ativan is lorazepam. Just like instead of Valium, they may call it diazepam. Instead of calling it Versed, they may call it midazolam. Anything that ends in AM is a benzo. All right, anything that ends in AM, diazepam, midazolam, lorazepam, anything that ends in the AM is typically a benzo. All right, DKA. Instead of fast onset, it's slow onset. A lot of times they'll have warm and dry, sugars high, flush it by. They'll have polyuria, polydipsia, polyphagia, Kussmaul's, poor wound healing, maybe you have some sort of acetone or fruity breath. Why do they get poor wound healing? Neuropathy. Remember what we talked about yesterday? Where does the sugar go?
Down feet.
To the bottom of the feet. What's it going to do? It's going to eat the feet. All right? Now, they may also have what's called dry mucous membranes. What are dry mucous membranes? Dehydrated. If we looked in everybody's mouth in this room, how we can tell if they're dehydrated is if they got saliva in their mouth. Their membranes are moist. DKA, because they're still in all the fluid from the body to dilute the sugar, their mouth will be extremely dry and cracked. Does that kind of make sense? So that's what we're looking at there. Now, let's look at what happens. In the bloodstream, they got all the sugar in the world, but they're not able to move it into the cells. So the cells have no sugar. Meanwhile, the vessels and the receptors inside the bloodstream are going, dude, your sugar's too high. This thick sugar goes to the kidneys, and if you remember yesterday, we talked about the tubulars. That thick sugar is going to go through the kidneys, and it's going to start to clog the kidneys. So in order to flush the kidneys and get rid of this high level of sugar, they're going to get polydipsia, which is increased thirst, and polyuria. They're trying to thin and dilute that sugar that's too sweet. That's where the polyuria and the polydipsia comes from. The polyphagia comes in because they have no sugar in the cell. Well, if you have no sugar in the cell, you must have no sugar available. So the cells relay that message to the brain. So the brain says what?
We don't need it.
We need to eat. So they start eating more food than they typically eat, but they still can't move the sugar into the cell. So as a result of that, their blood sugar level continues to climb, but they do not get any of that sugar into the cell. So initially the cells will start to burn fats and lipids. This breaks down to lactic and pyruvic acid, which breaks down to carbonic acid, which broke down to the water and carbon dioxide. They're peeing off the water and they're blowing off the CO2. This will go on for a couple of days. They run out of fats and lipids to burn, and they still don't have any sugar in the cell, so now they'll start to break down muscle. The muscle will release protein and branch-chain amino acids. The proteins will clog the kidneys and lead to renal failure. The amino acids will lead to the ketonic or acetone odor as they're basically decaying and eating their own muscles for energy. This is how they end up developing Kussmaul's to blow off the acid, and this is how chronic diabetics end up with renal failure from all the trash clogging their kidneys. So our job is, warm and dry, sugar's high, we need to flush it by. How do we flush it by? We give them fluids. Tuesday and Wednesday's class brought up, could we give them albuterol? Could you give DKA albuterol? Think about it. What did we talk about yesterday albuterol does? It increases the beta cells, opens them up, and it moves what? Electrolyte. Potassium. So in renal failure, If they start to retain water, they start retaining sodium, they start to retain potassium. If the butyrol moves the potassium and it bronchodilates, it gives more surface area to blow the trash out. Well, this person is already having Kussmaul's, right? So what happens if I make the lung surface area bigger? Can it get more acid from the blood and try to eliminate it? And three of y'all's classmates said that they had some DKA patients. One of them they transported, and then a couple of them came into, I think it was either Parkland or one of the other ERs. They said they were giving them breathing treatments to help blow off the what? Acid. If we stop and think about it, it makes sense. I make your lungs bigger. I move your potassium by giving you a butyrol. Now you have more surface area to blow the trash out. Something to do. Registry is going to say warm and dry, sugar's high, flush it by. Definitively, they need an insulin drip to be able to move the sugar from the bloodstream into the cells. But something to think about real world, acidosis and its metabolic, think about throwing some albuterol in. It will help them more than the bicarb ever will. Albuterol is a great drug for metabolic acidosis to help dilate them and blow off all the acid. All right? Now, what happens if they have no Kussmaul's and no odor? And your glucometer says high, but it flashes a negative K or NK.
Oh, they went to the other shit.
HHNKS. Hyperosmotic non-chaotic syndrome. What happens in HHNKS is they have sugar, but they are able to move just a little bit into the cell. Because they move a little bit into the cell, they don't break down the muscles and release the amino acids and the protein. Most of these people that end up in HHNKS don't know they're diabetics, or they're type 2 and they don't know their oral pill has stopped working. All right? People that are type 2 diabetics and they take metformin or glucophage or glyburide, they wake up in the morning, they pop a pill, they go about their day. They don't have glucometers, they don't have to check their sugar. Because their body is still producing insulin, they're put on those oral meds to block the conversion of simple carbohydrates to sugar, or to help the beta cells, which are located in the isolates of Langerhans, which will be a test question, in the pancreas. That's the way oral meds work. Versus if I'm an insulin-dependent diabetic, I have to check my sugar, and based on my current sugar level and what I'm fixing to eat, I have to take a sliding scale of insulin. I have to take some short-acting versus long-acting. I may have to take 70 units of this one, 30 units of this one. A type 2 diabetic that's on pills doesn't typically have to do that because they're still producing some insulin. So this person takes in, let's say, 200 parts sugar, burn 10, net gains 190. 200 parts sugar, burn 10, 380. 200 parts sugar, 570, burn 10, they're at 760. This person will look like DKA, act like DKA, but the respirations will be normal, so they won't have Kussmaul's and they won't stank. All right? Bottom line is, warm and dry, sugar's high, flush it by. If you see a test question and it said blood sugar's high, patient has respirations at 16, polyuria, polydipsia, and polyphagia, what should you suspect? HHNKS, because it doesn't have Kussmaul's. You have an unresponsive patient, respirations 28 and deep, polyuria, polyphagia, polydipsia, what should you suspect? DKA. Your glucometers, depending on which manufacturer you have, somewhere between 4 and 500, they typically switch over from giving you a number too high. The newer ones will flash a K plus or a negative K, or it'll say no ketones. If it says no ketones, it just means that they haven't produced enough trash for it to be detected in the machine, or it could be that they still are producing a little bit of insulin, and then they're in HHNKS. HHNKS can last a whole lot longer than DKA can because they're still producing some insulin. Most of the time, DKA will start in a couple of days to a week. HHNS can last for a month or longer. A lot of times, if they're an elderly type 2 diabetic and their pills quit working, they're going to think they have the flu. Man, I'm achy all over. I'm tired. I don't feel well. All I want to do is eat, drink, and sleep. Oh, you must have the flu. What's going around? So they don't go to the doctor and they delay it until eventually they become altered level of consciousness and family calls us out. How it occurs in kids, and probably the highest blood sugar I've ever seen alive on anybody. We had this girl, she was about 11 or 12 on Weathered Street. Parents call us out. She's altered LSE about 9 o'clock in the morning. We get there. She's covered in urine. Smells like ammonia because she pissed herself in the bed. She's altered level of consciousness. Very warm to the touch. She's breathing. Not real deep. She is breathing. She barely responds to pain. We check her sugar and it says high. So I asked parents if she's a diabetic. They said no. I don't recall if there was family history of diabetes or not, but whatever. Obviously, she has a sugar issue. Says high, she's altered. Start an IV on her. We take her to Baylor Irving, which was a couple miles down the road, and they do an iStat machine on her bedside, and her sugar was over 3,000. God damn. She is in a massive HHNKS. So I get to talking to mom and dad, and I'm like, just out of curiosity, how long has she been sick? And she goes, well, for the past couple of weeks, she's been real achy. Her joints have been hurting her, and all she wants to do is eat, drink, and sleep. And I said, yeah. And she goes, but our other kid did that when they went through puberty, so that's what we just thought. And that's what kids do in puberty. They eat, they drink, they sleep, they ate, and they stink. Especially boys with the BO changes and stuff. And so she goes, we thought it was just that, but the last 3 nights in a row, she's wet the bed. It's not normal for an 11 or 12-year-old to just start wetting the bed. So she was wetting the bed at night, actually trying to eliminate what? The waste and the sugar. So when she couldn't wake up, she called us. I said, man, it sounds like she's got diabetes. And I said, just out of curiosity, how much has she grown in the last year or two? And she had grown like 1.5 feet in less than 18 months. So what happened was when she was a little bitty girl, her beta cells of her pancreas could produce enough insulin for her body size and the amount of food she ate. But now that she's gone through puberty and had this growth spurt and metabolism change, her pancreas is too weak to keep up with that new body size and metabolism. That's why she developed diabetes at puberty. That's why it's called juvenile onset or type 1 diabetes, and she'll probably be on insulin the rest of her life. That's why it's called juvenile onset, because it occurs at puberty and they essentially outgrow their weak pancreas's ability to produce enough insulin after they complete puberty. Yes?
That high sugar can cause like achy joints, that because it dries out.
It's just extremely thick and hard to push through there, and they're building up all that acid. So they're essentially getting lactic and pyruvic acid built up in Charlie horses, and your vessels are narrow as it moves through the joint, and that's why they get achy in the joints.
And your pancreas can never catch back up?
Not typically, and that's why those 10, 11, 12-year-olds will end up on insulin or insulin pumps the rest of their life. So if it looks like DKA, it acts like DKA, but it don't breathe or stink like it, HHNKS. Treatment for us is the exact same, which is what? Fluids. Definitively, they need insulin. All right? Good on that? Sickle cell. Sickle cell not only occurs in African Americans, but it can also occur in anybody from tropical climates in Central America. Can also occur from patients around the Caribbean nations, Mediterranean, and Egypt.
Mayans.
People from tropical climates. Tropical climates have mosquitoes. Mosquitoes carry malaria. Sickle cell is a DNA change that helps make people immune to malaria, which is a great thing if you are from somewhere that has large amounts of malaria mosquitoes. So it's not just in African American ancestry, Central American, Caribbean, certain parts of the Mediterranean, along the Nile River in Egypt. Those cultures and those ancestry backgrounds have a history of sickle cell, not just African Americans. All right? Now, what ends up happening in sickle cell is normally my red blood cell is able to carry oxygen and carbon dioxide, and it's called carboxyhemoglobin. In the middle of a sickle cell crisis, instead of being shaped like a whole red blood cell, it's sickler in nature. Because it's sickler in nature, it cannot transport oxygen or carbon dioxide. Most importantly, it can't carry carbon dioxide. So it's not able to transport oxygen to the muscles, so the muscles go from aerobic to anaerobic metabolism, produce a whole bunch of trash and acid. Normally when we produce trash and acid, we'll vasodilate, and all that trash and acid will dump onto the red blood cell, and it will carry it through the kidneys and to the lungs to eliminate the waste. But because it's sickler in shape, there's nowhere for the acid or trash to ride. So they'll get extreme vasodilation to try and get rid of the acid, but nothing to carry it out. So this acid starts to build up in all the tissue and the muscles. They get vasodilation, which causes a fever, which causes tachycardia. They may even get a priapism in a male patient. Since there's nowhere for this acid to go, they end up with a simultaneously head-to-toe Charlie horse from the lactic cuprovic acid. I woke up this morning and I don't know what I did yesterday or last night at the station, but I had a giant Charlie horse right there on that inner muscle. It hurt like a mother. Imagine having that from your pinky toe to your hair and everything in between simultaneously.
I was playing football. A couple of my teammates
Had sickle cell?
I thought it was full of shit because we used to run a lot. I'm tired. And just like they were gonna sit out, like pour water all over the whole body. The whole team was looking like, they always do that shit. Like, you know, it's
right.
like trying to get out of running. Like now learning about it, like they probably were like in a lot of pain.
So, and I'll talk about that. Did you play college ball?
Yes, sir.
And part of the NCAA intake is all athletes now get a sickle cell test as part of their blood work. Because there's a couple of things that help trigger that. First of all, we have all that acid. I don't care how much you worked out in high school. When you go to play college ball, it's a different level of working out typically. And there is a lot of anaerobic exercise that's involved in that training because now you have professionals that are specifically training you for a sport. So what was happening is we would have some of our college athletes who didn't know they had sickle cell. They'd go to college and they'd start putting them in anaerobic workouts. Well, anaerobic workouts where they're producing a lot of acid can trigger recessive sickle cell traits to activate. So there ended up being a couple of college athletes who died during conditioning and working out because they were producing all this trash, but they had no cells to carry the trash out. So we had some of the athletes die, so they ended up making mandatory sickle cell tests for anybody that plays college sports. Elevation will also affect sickle cell because if I can't transport oxygen and then I go to elevation and thin air, it makes it harder for me to move oxygen and move the trash. And there's a couple players in the NBA that can't play in Denver because of the elevation. The other thing that ends up happening is because of the severe Charlie horse head to toe, they have chronic muscle contractions and muscle cramps. A lot of times the only thing that will relieve the muscle contractions, muscle cramp, is Dilaudid, which is a potent pain med. The problem with Dilaudid is it's highly addictive. So we end up stereotyping, even though we shouldn't. We run on that sickle cell person, they feel a crisis coming on. They feel themselves get short of breath, and they start getting leg cramps. If they don't get treated, their entire body is going to lock down and have a Charlie horse simultaneously. So they barely feel it on, they pack their bags, because they know they're going to be at the hospital for several days, and they meet you on the front porch with the bags packed, and they go, my sickle cell is acting up. And you're like, you want to go to the hospital? And they're like, yep. I know it's a pain in the ass. All right? Hey, I'm guilty. But you need to stop and understand. That disease is so painful and debilitating that if it activates as a toddler, they're probably not going to make it in their 20s. Because not only do they have a huge amount of pain that goes with it, these sickle cells will end up clogging the kidneys whenever they have a sickle cell outbreak. It can't go through the kidneys, so it will clog them and put them into renal failure at a young age. If we go back and we look at the coronary and cerebral arteries from yesterday, in all the turns and bends, those sickle cells will get stuck in the vessels of the brain and of the heart, and because the blood doesn't move, it thickens, and it causes them to have heart attacks and strokes at a young age. It is a very debilitating disease and extremely painful. Now, one of the negatives is a lot of times, because the Dilaudid is so addictive, they end up having withdrawals from the Dilaudid. So now the question is, are you really having a sickle cell crisis, or are you having withdrawals because you haven't had Dilaudid in a few days? Me personally, I don't give a shit. I would give you Dilaudid every day, because that's better than them living in the pain that they're living in, because they do not have a good quality of life if they're having constant sickle cell outbreaks. We used to have a kid in our district in twos that by the time he was in high school, he was on dialysis 3 days a week. By the time he was 18, he had already had a stroke and a heart attack from it. There is a stigma attached to sickle cell. There's no reason to be. It is a debilitating, brutal disease. I don't know if your two teammates were using it or not, but I can tell you this, if it was hot and they were doing a lot of sprints, it would kick them in their butt, even with a mild case of sickle cell. And they would cramp, unlike you or I would ever cramp. There's usually not much we can do for it in the field other than fluids and pain management. A lot of times they're going to tell you morphine or fentanyl don't work. They're going to wait on the Dilaudid. That's fine. If you give them high flow oxygen, because they're going to be short of breath because they can't carry the trash out, if you give them high flow oxygen and they're in the middle of a crisis, it will make them worse, the oxygen can. They'll get more short of breath, they'll get abdominal cramping because of the thickness of the blood and the stacking at the sickle cells. A lot of times they'll have severe joint pain. All we can do for them then, if the pain meds won't work, is fluids. At the hospital, they're going to give them pain meds and try and relax them. Depending on their acid levels and their kidney function, they may have to do acute dialysis on them. They may even have to give them whole red blood cells to where they can transport oxygen and carbon dioxide until they get through this crisis. It is a debilitating, brutal disease. Our job is check our egos, check our stereotype bullcrap at the door, and take care of those people. Okay, yeah, they pack their bags. I get it. It's a pain in the ass. Yeah, they may be drug seeking. Okay, but you know what? I'd rather that dude or that girl have Dilaudid every fucking day for the rest of their lives, because their quality of life, if they're having constant sickle cell, is not good. And they're going to be lucky if they make it into their adult years if it activates at a young age. Yes, sir.
What does the weather change have to do with it? I met someone who was saying that, when the weather changes, it does something to...
So it could be the air pressure and the humidity. So think about last week, we've been relatively cool.
Right.
And then all of a sudden, one day last week, it got in the 80s, and that it was that thick air, you're like, God, it's hot, sticky, and hard to breathe. You and I can transport oxygen and carbon dioxide efficiently. When they have that weather change and that thick humidity and temperature, they can't eliminate the CO2 and they can't transport the oxygen as efficiently, so it makes them build acid quicker and go into sickle cell crisis quicker. Same reason why the outside air pressure pushing on me helps me move my blood. When I get up in high elevations, your things expand and your pressure goes down because there's not as much gravity, not as enough air force or air pressure on it, so to speak. You and I's body will adjust to it a couple of days. Because of their sickle cell, they can't, because they can't overcome those changes because they already have issues with their blood volume and their red blood cells.
What does the trait do?
Do what?
Trait? Sickle cell trait?
So the sickle cell traits have to do with what did they get from their parents. So let's say that parent A has a sickle cell trait, but it's not active in him. So mom has recessive sickle cell. She got half of the sickle cell trait from her parents, but it's not activated in her. Dad has half the sickle cell trait, but it's not activated in him. When you put them together, it's likely to end up with their kid developing sickle cell. Or let's say that I have sickle cell trait, but it's never been activated, and I end up in massive metabolic acidosis from that workout or sepsis or something like that. It can end up making that sickle cell trait end up producing acute sickle cell crisis. Not very often, but it can. And that's what happened in a couple of those athletes is they had sickle cell, but it had never been activated because they had never been metabolic acidotic enough to end up basically making it, stimulate it to where it happened. All we can do for it, fluids, pain management, be careful with oxygen administration. If their pulse ox is normal, don't give it to them. It can make it worse. All right? Any questions on that page? Top of page 7. Let's get through this and we'll go to lunch. What did y'all print?
I don't know.
All right, page 10. Oh, y'all didn't print it front and back.
Oh,
That's the issue.
Maybe that's
okay. All right, I got you. I was like, wait. Acute renal failure. How's that? Either page 10 or 7, depending if you're front or back or not. Acute renal failure. What happens in acute renal failure would be like the sickle cells clogging it. They're not on dialysis, but something clogs their kidneys. It could be massive dehydration. It could be DKA. It could be a burn patient where they've broken down all their cells and their fat in their muscles and it goes to the kidneys. Basically, acute renal failure is low blood pressure can cause it, and thick blood that clogs the kidneys can cause acute renal failure. Once the kidneys are clogged, it's going to make them retain water, which is going to make the blood pressure go up, which is going to make them retain sodium and retain potassium, which puts them at risk for seizure activities and a CHF presentation. These are people that are not on dialysis, but they end up in renal failure. Let's say it's 110 degrees and we decide we're going to run a marathon and we've never trained for it. We're going to end up dehydrated. All the acid and all the byproducts of us running, not being conditioned, not being hydrated is going to clog our kidneys. And as soon as our kidneys get clogged, we can't take out the trash. That would put us in acute renal failure. Things like that. Now, if they start to retain potassium, you're going to see this on your QRS in your T wave. Your T wave becomes what? Tall and peak. And when your T wave gets 50% the height of the QRS, they are at risk for going into torsades. If their rate is sinus to sinus tach, and we saw tall peak T waves, and it's acute renal failure, or somebody that missed dialysis, our treatment is going to be albuterol and bicarb. Albuterol is going to help move the potassium, and it's also going to help blow it off. the bicarb is going to help deactivate all the acid that's floating around in it. So, tall peak T-waves, the rate's not BTAC or torsades, and they're not bradycardic, they're going to get albuterol and bicarb. If they go into torsades, they get what drug? MAG, 1 to 2 grams over 10 to 20 minutes. What happens if they do this? And you're like, man, they got a P wave, it's extremely long PR interval, and the QRS is forever before it gets to the T wave. It's not really a block. It's just a super wide, bizarre QRS, and everything is extremely sluggish. And the bradycardic.
Calcium
They
chloride.
get calcium chloride. Here's what's happening. The sodium potassium is so elevated, it can barely move in and out of the cell, and it takes forever. Well, left to right on my EKG strip is what?
6 seconds.
Time. Time. So what this is telling me up here is it moved, but it took more energy to reset it. That's why I had a tall peak T wave. This one right here is taking forever for that sodium potassium to move in and out of the cell. That's why that QRS is so wide and slow. And what did we say yesterday? Renal failure, PEA, asystole, or bradycardia, we use what drug to speed it up? Calcium chloride. Calcium chloride. Right? And that goes for acute or chronic. Acute, they're not on dialysis, but something caused their kidneys to fail. Chronic, they are on dialysis, but they missed it. All right? They missed dialysis.
You said bradycardic VA.
Asystole. They get calcium chloride.
Is that only if you know the history of?
Or if you saw this with PEA, or you saw something that would point you towards acute renal failure. Let's say that it's early July, and we had a nursing home patient with dementia get out of the nursing home. They find him 16 hours later, middle of the day in the park, hot to touch, low BP, and we see that wide, bizarre rhythm. That would be acute renal failure because of what? Dehydration. Or if I said you have a Monday, Wednesday, Friday dialysis patient, today's Friday, they haven't been dialysis since last Friday, and you have one of these presentations in the bradycardic, well, I know they haven't taken out the trash in a week. If they haven't taken out the trash, their electrolytes are out of whack, they're slow, I need to speed them up with calcium chloride. Those would be the instances. The one that they usually do on the registry is it says, you're working a cardiac arrest, you feel a vibrating piece of metal in the left arm. What's a shunt do? You ever touch the shunt in the arm? That's a dialysis patient. So it says you have a 72-year-old male, you're working in a cardiac arrest, you notice a piece of metal in the left arm vibrating, and family tells you he hasn't gone to the clinic like he's supposed to. So I got the buzz for the shunt, hasn't been going, and it says, after epi, what drugs should you consider? And it says bicarb, calcium chloride, adenosine, and atropine. Calcium chloride because it's a renal failure and cardiac arrest. If I run somebody in the hall here and I go to start an IV in their left arm and I feel a shunt, got to go to the right, and that's a good indication they're on dialysis. And then if I put them on the monitor and I see something wide and slow or bizarre, there's a good chance if it's electrolyte, we'll try the calcium chloride. But the first drug, if they have no pulse, is still what? Yes.
So there's never going to be a point where we poke a shunt or anything like that.
Shouldn't be. Shouldn't be. Shouldn't be. We don't have the training or the specialized needles, and if you do use the wrong equipment, they can bleed to death in a hurry.
Well, not be touching that.
Yeah, don't touch it. All right. So that's our acute versus chronic renal failure. If vitals are stable, albuterol and bicarb, PEA, bradycardia, calcium chloride, definitively, what do they need? Dialysis.
Is that why people get dialysis like 2 or 3 times if they do go to acute renal failure, dehydration?
They're trying to get all the trash out. Trying to get all the trash
And
out.
that doesn't mean they need dialysis for the rep. It's just
Correct. Like my grandfather, before he died, he became extremely septic. Well, when you become extremely septic, what happens to your pressure? Goes down. When your pressure gets below 90, your kidneys quit filtering and quit taking out the trash. So they kept giving him all this fluid, and they put him on vasopressin to try and get his pressure up. They finally get his pressure up. Well, he hadn't pissed off any of that fluid. So they get all of his they finally get his pressure up above 90. Well, all that fluid they had given him now goes to the kidneys at once with all the trash. So now all of a sudden his kidneys are clogged and he has no kidney output. So they had to do emergency dialysis on him a couple of times. And that's how septic patients with low blood pressure can end up in acute renal failure. Because the kidneys are the first organ to turn off and the last organ to turn back on. When you have surgery, what do they tell you? You can't leave till you what? Because that tells them that now you're able to process and eliminate the surgical beds, the paralytics, and start taking out the trash. Because it's the first thing that shuts off during stress and low blood pressure, and it's the last thing to turn back on.
What about PICC lines, and when can we access those per BioTel?
No,
Okay,
y'all can't. Don't do it.
I didn't think so.
Don't do it.
I didn't. I just started.
Don't do it for now. Don't do it. I'm just going to say don't do it. And down the road, if you get specialized training on a dual lumen where it has a red and blue tube, yeah, we can, but waste the first 10 cc's because it has heparin in it, and then we can use it. But for y'all's level right now, don't do it. It takes specialized needles we don't carry per registry. Let's not do it. Okay? Once you get out there with the red patch and they put you through a little bit different class, maybe. But last thing I want is y'all going out there and jacking something up. Because depending on the type of the port, like some of them take a Hickman needle, which is 90 degrees bent. They take different types of, and if you bust it, they got to go in and surgically replace it. So
This dude looks like a normal.
if it's a normal, just regular IV,
Yeah.
yeah, but typically waste the first 10 cc's because heparin's in it to keep it from clotting. All right, renal calculi, flank pain radiating to the groin, dysuria. What is dysuria?
Inability.
Difficulty urinating, decreased urine, hard to pee. So, flank pain radiating to the groin, dysuria, fever. You're going to want to pick kidney stone. The registry is probably going to use the term renal calculi, which means calcification stone of the renal duct. All right? Treatment, fluids, Toradol. Toradol is a liquid ibuprofen. Ibuprofen is called an NSAID, non-steroidal anti-inflammatory drug. The reason why an NSAID works better than morphine or fentanyl, morphine and fentanyl work on the pain, but an NSAID will relax it and take the inflammation away. If I relax the renal duct, what's it allow the stone to do? Move and pass. So Toradol is the liquid ibuprofen that works really well for kidney stones, muscle strains, and soft tissue injuries. Yeah, morphine and fentanyl will work on the pain, but it won't relieve the kidney stone and help it move. That's why an NSAID is a better drug for it. On the registry, NSAIDs are used for kidney stones, sprains, strains, soft tissue injuries because they help with the swelling. Does that kind of make sense? Versus fentanyl and morphine is more specific to like the broken bone and cardiac pain. Gastrointestinal emergencies, if their belly is warm and distended and they have a positive tilt test, which means when they go from sitting or lying to sitting, you're sitting to standing, heart rate goes up by more than 10 and systolic drops by more than 10 points. That's considered orthostatic hypotension, which means low BP when sitting up, or a positive tilt test. That's usually a sign of low container volume. If they've had nausea, vomiting, diarrhea, it could be hypovolemic shock. If their belly is warm and distended, could mean they have an abdominal bleed, like a GI bleed. All right. Usually, we're going to end up giving a positive tilt test, some sort of fluid bolus. Liver injuries, right upper quadrant, it's your solid organs. Solid organs have somatic pain, which is constant. Constant pain radiates to the same shoulder. So if I have constant right upper quadrant pain, you radiating to the shoulder, you should suspect what? Liver. If I break my ribs on the lower right, ribs are broken, your biggest concern is what organ? Right. Liver. Liver because it's solid. Secondary organ would be. So I want to worry about the solid organ first, getting lacerated by the broken rib. Hemorrhagic shock. My secondary concern would have punctured the gallbladder and caused sepsis. All right. A couple other things with the liver. If they have hepatitis, they'll be jaundice or have yellow eyes. If they're a chronic alcoholic, they'll get what's called hepatosplagmia, which basically is a large engorged liver where you can basically feel it underneath the rib cage and palpate it because you're putting more alcohol through it than the liver can process. As a result of that, the liver ends up doubling in size. Because they're putting so much alcohol through it, they can no longer produce platelets, which makes their blood thinner and they're at risk for bleeding. The other side of that equation is it starts to leak toxins out of the liver through the hepatic portal. The hepatic portal is a tube that goes from the liver to the esophagus. The toxins and the acid leak into the esophagus, and when they lay flat at night, those acids and toxins eat away at the esophagus, and it gives them what's called esophageal varices, which are ulcers up and down the esophagus. If they're vomiting a lot, they can end up tearing one of those ulcers, and then they'll have bright red bleeding. That's called a Mallory-Weiss tear. A Mallory-Weiss tear is an airway complication. It's a tear in the esophagus. They have large amounts of blood, which makes them at risk for aspiration. And because they don't produce platelets, they can't what? Clot it. So a lot of times they'll have to go in, cauterize the esophagus, and give them a platelet transfusion to where they can start clotting and fixing their own holes in their body. So if I said 57-year-old male, smells like alcohol and emaciated, it means he'll choose alcohol over food, so he's all skinny and malnourished. That's what emaciated means. He's drinks alcohol, emaciated, and he has sudden bright red vomit. You should suspect a what? Mallory-Weiss tear. Alcoholic, vomiting, bright red, Mallory-Weiss tear. Treat it like you would hemorrhagic shock, take him to the hospital. Stomach, if it's warm and distended, has bruising around the belly button, we're going to consider internal hemorrhage. Maintain a radial pulse, which is a systolic of approximately 80. Spleen, left upper quadrant, lower rib fractures, constant pain radiating to the shoulder, upper left quadrant injury with signs and symptoms of hemorrhagic shock, most likely is the spleen because it's a solid organ. Take him for surgical evaluation. Food and liquid will not typically make the spleen hurt any worse. Right upper quadrant, crampy, colically pain, worse after fatty, greasy, spicy foods. It's gallbladder. Gallbladder produces fat stones called cholecystitis. The problem with gallstones or cholecystitis is they move towards the pancreas and they will clog the pathway for moving food and liquid from the gallbladder to the pancreas, and it can end up cutting off blood flow to the pancreas and cause pancreatitis because they're tied together. So, right upper quadrant, crampy, colically after greasy, fatty foods, gallbladder. Left upper quadrant, crampy, colically after greasy, fatty, spicy foods, alcohol, is the pancreas. The pancreas has to inject insulin and glucagon into the bloodstream and into the food for it to be broken down. So that's why it hurts when stuff moves through it. If nothing's moving through it, it's not going to hurt. That's why the gallbladder and pancreas are crampy colically after food and alcohol.
What if you have your gallbladder removed? What?
A lot of times the pancreas will pick up the slack.
Okay.
Both the pancreas and the gallbladder, I'm at risk for what? What type of shock? Sepsis. Versus spleen and liver, hemorrhagic. Gastric ulcers are basically scabs and sores on the stomach lining itself. Can be caused from acid reflux, can also be caused from diet and lots of spicy foods, etc. If they have gastric ulcers, what medication is contraindicated? Aspirin, acetylsalic acid. The reason why acetylsalic acid is contraindicated because of the acid from the aspirin will eat away at the scab and make them bleed more. If they're bleeding in their stomach and it mixes with stomach or acid, it will basically make the blood into a tarry gel. If they pass that blood out the rectum, it will be dark and tarry, and we call that what? Melena. All right. If they're throwing up bright red blood, it's called what? Hematemesis. If they're shitting bright red blood, hematochezia, bloody cheese. You guys at lunch, if you're bored, Google the Bud Light Super Bowl cheese commercial. You ever seen that?
No, that sounds good.
Yeah, they're working in a deli, and when I was a kid, you always called farting cut the cheese. And so this guy, he's in New York, and he's like, man, I can't cut the cheese. And the guy's like, let me pull your finger. They'll help you cut the cheese. And he's like, that worked. And then they talk about women cutting the cheese. They don't do it right. Yeah, but it stinks. And they're in a deli cutting the cheese. It's great. It's funny. So I remember bloody cheese related to the rectum, because I always remember cut the cheese was a fart as a kid. So bloody cheese comes out the rectum. All right? Bladder. A full bladder or empty bladder is most likely to be damaged in a car wreck. Full, because it basically is like a balloon. It's inflated. It will pop. If they do have a bladder rupture, they will have blood in the urine, low blood pressure. They may wet themselves, and they're going to have lower pelvic pain. May also have some pelvic tenderness as a result of that. Treat it like you would hemorrhagic shock. We talked about bruising over the kidneys. That's called gray Turner's, indicative of a kidney laceration. Take them to a trauma center. Come back at 12:45 and we'll be on page 8. We'll be done about 3-ish today, maybe a little bit later.